We are live.
Okay. Good evening, friends, and a happy new year. Welcome to this 26th episode of All India Postgraduate Teaching Program, which is a new initiative from ARC AOS. This is a postgraduate program with a difference because it covers the uncovered aspects of teaching programs, unlike other programs. For example, case presentation, journal clubs, OSCEs, and didactics on topics which are not comprehensively available in a textbook. In fact, on the last Thursday, we had two short cases on retina. Today, here we are in this 26th episode, we are having our sixth journal club. Today in the journal club, it would be for basically the theme is UVA. And the first article would be presented by Dr. Akshat Jain, who is a second year resident at LV Prasad Eye Institute, Bhubaneswar. And the second article will be presented by Dr. Anu Teres Thaliad, who is a primary DNB resident at Sankara Eye Hospital, Bangalore. I am thankful to the mentor from LV Prasad Eye Institute, Bhubaneswar, Dr. Anup Kelgaonkar, who is a faculty uveitis and vitreoretina services at Bhubaneswar LVP campus. And I'm very proud of him because he belongs to the place where I hail from, that is Nagpur. We are proud of you, Dr. Anup. We are also thankful to the mentor from Shankara Eye Hospital, Dr. Nidhi Pandey, who is a senior consultant in UVA at Shankara Eye Hospital, Bangalore. Thank you, madam, for mentoring your student. Of course, my special thanks also goes to the three discussants, Dr. Amit Khosla, who is a senior consultant at Sir Gangaram Hospital, New Delhi, with a special liking for uveitis, Dr. Yogesh Kamath, sir, who is a consultant UV and cataract at Kasturba Medical College, Manipal, Udupi, and Dr. S. Balamurugan, who is a senior consultant uveitis department at Arvind Eye Hospital, Pondicherry. I'm really thankful to all the discussants for being sparing their valuable time for our postgraduates. Now, can I request our first, without much ado, now it's time for us to move to the articles directly. I would request Dr. Akshat Jain to now share his screen and let's move on with the this particular event.
So, a very good evening to one and all. I welcome you all to the Journal Club session of Postgraduate Teaching Program of All India Ophthalmology Society. I would like to extend my warm regards to the esteemed panelists and dear participants. I am grateful to the Academic and Research Committee of All India Ophthalmology Society to provide me this opportunity to present today's Journal Club session. I am Akshat, primary DNB resident at LV Prasad Eye Institute, Bhubaneswar, and the session shall be moderated by Dr. Kelgaonkar, Head of Department, Uveitis and Vitreoretina Services at LV Prasad Eye Institute, Bhubaneswar. I welcome you all. I hope my slide is in full screen and I am audible.
Yes, Akshat, you can go ahead. You're audible and visible.
Let's get started. These are the common acronyms that I would be using in my session. So viral herpetic anterior uveitis is a very common entity in a uvea OPD. The viral uveitis can be caused by mainly three viruses of herpes family that are herpes simplex virus, varicella zoster virus, and cytomegalovirus. Well, sorry for putting that busy slide, but it is important to know that the studies that have been conducted in past of viral anterior uveitis either had variable sample size or they did not or the presence of virus was not confirmed by the presence of molecular diagnosis or by polymerase chain reaction. So in the year 2020, Dr. Kalpana Babu madam published a review article in which they described the clinico-demographical features of three types of viral anterior uveitis. As it can be seen, while the herpes simplex virus affected mainly 40 to 50 years of individuals, while varicella zoster virus affected a relatively elder population who had immunocompromised status, while herpes simplex and varicella zoster virus had acute and sudden onset. Cytomegalovirus had a chronic and recurrent course. So far as intraocular pressure is concerned, it was associated with all three types of viral anti-uveitis. But it is very important to note that the raised intraocular pressure was very much high associated with cytomegalovirus. So far as cornea findings are concerned, the cytomegalovirus was associated with immune ring keratitis, while disciform keratitis in herpes simplex virus and nummular keratitis in varicella zoster virus were specific findings. So far as the size of keratic precipitates on endothelium was concerned, the HSV and VZV presented with small to medium sized KPs, while CMV presented with medium to large size KPs. The neuronal invasion of iris tissue leading to D-shaped pupil was described as iridoplasia, was seen mainly in herpes simplex virus and varicella zoster virus. So far as iris atrophy is concerned, the iris atrophy was associated with all three types of viral anti-uveitis, but nothing was concluded so far as the types of iris atrophy was concerned. So let's move to our article of interest this evening, that titled as Distinguishing Features of Anti-uveitis Caused by Herpes Simplex, Varicella Zoster, and Cytomegalovirus. The article was published in American Journal of Ophthalmology in March 2021. The objective of study were to distinguish the clinical features of herpes simplex, cytomegalovirus, and varicella zoster virus, which are proven either by polymerase chain reaction positivity or varicella zoster virus had a specific characteristic clinical skin appearances. It was conducted by a Japanese group at 11 tertiary centers. It was a retrospective multicentric study in which the patients were recruited over 6 years from 2012 to 2017. The study included the individuals above the age of 20 years having the minimum follow-up of 3 or more months, and as mentioned, only the PCR proven cases in case of HSV, VZV, and CMV or presumed VZV due to specific clinical appearance of herpes zoster ophthalmicus. The various formulas and tests were done during statistical analysis depending on the type of clinical data. So these were the results. As can be seen, out of 259 herpetic anti-uveitic patients that met our inclusion criteria, the majority, that is 57% of them, was cytomegalovirus, followed by varicella zoster and herpes simplex virus. And out of 82 varicella zoster viruses, 50 had PCR positivity, while 32 patients were recruited on the basis of classical signs. However, study did not mention about the PCR status in those 32 cases. So far as the distribution of age and sex were concerned, all three viruses affected mainly the seventh decade individual in the seventh decade of their life. However, there was no significant difference in age. But herpes simplex and varicella zoster affected mainly females. However, in the cases of CMV, males were affected twice or even more as compared to their female counterparts. The clinical presentation was noted to be in herpes simplex and varicella zoster was to be acute sudden course, while cytomegalovirus presented with more insidious onset, chronic course, and even showed recurrence after the treatment. So these are the ocular symptoms and signs results. As can be seen, the symptoms like ocular hyperemia, pain, blurring of vision, the signs like ciliary injections were significantly higher in herpes simplex and varicella zoster anti-uveitis as compared to cytomegalovirus. Similarly, the medium to large size KPs were also significantly higher, and their difference was significant as compared to cytomegalovirus. But it is important to note the characteristic coin-shaped precipitates were significantly higher in cytomegalovirus. So these are the coin-shaped keratic precipitates. Similarly, the anterior chamber reaction was graded on the basis of standardization of uveitis nomenclature criteria, in which AC cells more than 0.5 and AC flare more than 0.1 was concerned. Again, these two were significantly higher as in HSV and VZV group as compared to CMV groups. But a characteristic finding, peripheral anti-SINK was higher in cytomegalovirus. Now, interestingly, all three viral anti-uveitis showed elevated intraocular pressure, but the incidence of raised intraocular pressure was much higher, and that had a significant difference from in cytomegalovirus from herpes simplex and varicella zoster virus. So, peripheral anti-SINK and elevated intraocular pressure can be interpreted as a feature of cytomegalovirus. Similarly, in out of 152, as high as 68 eyes had to undergo glaucoma surgeries. So higher need for glaucoma surgery in cytomegalovirus affected anterior uveitis was as high as around 45% of eyes. Now, as so far as iris atrophy is concerned, again the presence of iris atrophy was not significantly different, but the specific type of iris atrophy was associated with particular type of virus. Like segmental iris atrophy was a feature of varicella zoster virus, and that was significantly present. Similarly, diffuse iris atrophy was a feature of cytomegalovirus. So here I would pause and like to draw the attention, especially my fellow residents, that this is a diffuse slit lamp photograph of a eye. The patient was seen by myself in the emergency room, and he presented with a intraocular pressure in high 40s, about 42 millimeters of mercury, with sudden diminution of vision. And there were also keratic precipitates which are not clearly visible in this image. So I, at first instance, thought about to the attack of acute angle closure glaucoma, something like this. But when I discussed the same with Dr. Anup, he asked me to look at the diffuse iris atrophy. So the diffuse iris atrophy with the high intraocular pressure should not be missed, and the diagnosis of cytomegalovirus should always be on the cards. Again, so the treatment part, the HSV and the varicella zoster virus were mainly treated by both topical and oral acyclovir, while the cytomegalovirus was treated with ganciclovir. And all three, as expected, underwent topical steroid treatment. So why are there differences between CMV, HSV, and VZV? And why are the variation in clinical manifestation despite all being herpes virus? The answer lies in the pathogenesis of virus. While HSV and VZV spread through our neural pathway, the CMV spreads through blood or cardio or vascular system. The limitations as described by authors to the study were, since it was a retrospective study, so for the few patients only limited data on clinical manifestations was available. And also, since the inclusion criteria was more than 3 months, and as we saw, HSV and VZV had an acute, so that might also be a reason for the larger number of CMV cases in the study. Also, since it was a tertiary eye care center study, and it does not include the regular eye clinics or the ophthalmologist, so that was also reported to be the limitation of study. Finally, the authors concluded that herpes simplex virus and varicella zoster virus anterior uveitis had no differences in symptoms, signs, and complication, and CMV anterior uveitis had significant difference from HSV and VZV. And this summarized their characteristics as follows. The HSV and VZV anterior uveitis present with hyperemia, ciliary injection, ocular pain, medium to large size keratic precipitates with anterior chamber cells and flare, and posterior synechiae. While cytomegalovirus associated anterior uveitis presented with smaller keratic precipitates, characteristic coin-shaped KPs, the diffuse iris atrophy, the elevated IOP, and that too in high 30s or 40s, and with majority of them going for glaucoma surgeries.
Well, thank you, Akshat. Wonderful presentation there. And you dissected the article very carefully, minutely. And if I have to add few points here, these are that one needs to remember that the strength of this paper was PCR. All the patients recruited were PCR proven, and CMV was the one of the major viruses here that was slightly shocking to read and hear. I have one other alternative view that the strength of this paper itself was also a limitation because in clinic you're not going to do PCR for all the cases. So what about those patients who we diagnose clinically, treat clinically is the question number one. And the second question is PCR positivity in most of the cases is around about 40 to 60. So what about those patients that are non-PCR positive and though this article is fantastic, but those two questions remain unanswered. So Akshat and me had few questions for the panel. The first is in a routine uveitis OPD, would you like to perform PCR, which is for every case, or would it be targeted testing?
I think with that, all the discussions as well as the mentor of the other article can join in for the discussion.
Good evening, Dr. Anup. This is Dr. Yogesh.
Yes, sir.
I think the answers to both of your questions are there in the next article. So,
Okay, so we will definitely like to hear it.
but as you said, in my opinion, I am in a medical college and I have access to CMV and VZV, HSV PCR. But it predominantly, if all these clinical classical signs are there, I usually do not depend on these investigation of PCR. But at the same time, if there is a doubt, or sometimes our patients today are very well educated, they are reluctant to start on medications. I've had one patient come and tell me, if I take, you expect me to take valacyclovir or valganciclovir, which is very, very expensive. So in our setting, they are not usually happy to take this medication unless we have conclusively proven. So it's difficult to show them a journal article and convince them. So in those cases, if they are willing, I get a PCR done. But I usually will not prefer to do a PCR. I think Dr. Bala will agree because we both train from the same place, where financially PCR has got some limitations apart from the availability.
Yeah, Dr. Bala, you can have comment, and I expect the discussion to happen more at practical level for the postgraduate.
Yes,
We also
I
see
agree with
in the participant list. Dr. Minija, can you not join us for a while, as well as comment from Dr. Nidhi as well? Everyone can comment.
yes. I agree perfectly with the approach proposed. It is not practically feasible to do PCR in all the patients. We selectively do in cases where there is less of response to treatment, and we want to delineate whether the subtype identification of the virus is going to make a difference in the plan of treatment. By the meaning that we know that cytomegalovirus is going to respond only to the valganciclovir, not the classical valcyclovir. So by that, the treatment is going to be different. In such resistant cases, we end up doing PCR. But the title of that article was very interesting to me. I was curious to know what was the PCR that was used. Was it a qualitative or a quantitative, or was it a multiplex, or is it a qPCR? All this will make a difference because there can be false positive or false negative, as Dr. Anup has neatly illustrated in this list of questions. That we should not be carried away that all positive PCR is equal to positive viral infection, because this CME virus is ubiquitous and it can sometimes give a false impression as well. And we should focus on the quantitative titer as well before making a conclusion. It is definitely because of the virus. And the recent standardized uveitis nomenclature, SUN 2 has come on this viral uveitis, which classifies the viral uveitis based on the PCR parameters as well. The students who are interested can refer to those articles as well. I was the second important point from my magnifying lens was what was the exclusion criteria of this selected patients, because it was very surprising to see predominant number of patients with cytomegalovirus, which we hardly see in our Indian scenario. It is much lesser common compared to the other viruses based on our retrospective analysis in our setup. However, even Dr. Anup has sublimely said that he was surprised to see CME as super common in this article, because how they have ruled out the differentials of anterior uveitis with spiked IOP. We could have a differential, that is a common exam question that is asked for the postgraduates. It could range from infections like toxoplasma, sarcoidosis, even the 10-shaped VS, which they have identified in one of the viruses, could happen in a sarcoidosis as well. So ruling out the differentials becomes a key important question in a practical sense. So the students should pay attention, and hope all the clinicians agree with that.
Dr. Bala, Akshat, can you unshare your screen? And Dr. Bala, what should be the viral load, titer load that you should consider and give it a clinical importance from the therapeutic point? You said about the load which you should look into. Dr. Minija, why don't you join us for the discussion? We would love to have you, please. I see you in the participant panel.
Yes, sir. That is a beautiful question. I will share the references after some time. To my knowledge, it was ranging more than 500 to 600 copy units, and we have to be even the copy units can fool us. We have to correlate clinically like any other imaging. So we have to be very careful. And the common denominator is these viruses are ubiquitous. Be very careful to just brand them as viral uveitis, because I'm also super curious. In the lot of cases of cytomegaloviruses went in for surgeries. That was also our experience. But during the trap or the glaucoma surgeries of those cytomegaloviruses, whether the antivirals were continued both pre and post operatively to bring down the IOP, because trabeculitis is a classical pathophysiology operating in those cases. Controlling the inflammation of the trabeculum before taking up for a glaucoma surgery is a key point to be noted. Of late, now the glaucoma surgeon, the buzzword now is doing all this minimally invasive glaucoma surgeries targeting the trabeculum. So when the inflammation is exactly localized on the trabeculum, I'll be very skeptical in poking the needle there. So first control the inflammation, and then hope the other discussants agree with me.
Yeah, that was the second question that we had for discussion, Dr. Balamurugan, and you aptly answered it. I had one point to add here, and this is especially of value to residents when we're reading a paper. Now, one point that came up from discussion is CMV was very high in this. And interestingly, now you look back to the inclusion-exclusion criteria, you'll find that all patients of less than 3 months of follow-up were ruled out. Now, we treat most of our herpes and varicella for 1 month to 6 weeks or 2 months of antiviral therapy. So, all those predominant patients of herpes and varicella, herpes simplex and zoster viruses, won't be caught up in this less than 3 minutes of period. So, that's a catch there that CMV, how does it behave? It persists, it lingers longer. So, it would be more commonly caught when you put up an inclusion criteria of more than 3 months. And interestingly, the authors even acknowledge this point in their limitations that more than 3 months would be probably a catch there, because of which the CMV load was very high in this particular study.
Yeah, Dr. Yogesh, Dr. Amit.
So, from a different perspective, I'm in the car. I don't know whether you can hear me properly. Can you hear my voice properly?
Oh, Amit, you have to be a bit louder.
Hello?
Yeah.
Okay. So, basically, the PCR test is not available freely in the country, nor it is standardized. So, when you do an aqueous swab, you are not removing 1 ml. So, majority of the kits available in the market are for 1 ml. So, you have to dilute it with distilled water and you have contamination. So, PCR still in India is more for the tertiary care, not for primary or secondary care. So, if you have a patient where you suspect that you have a viral keratitis, you will start with acyclovir. If the patient doesn't respond and your pressures remain high, you can think of getting a test for CMV because the treatment is pretty high. Many centers try just the ganciclovir ointment in patients who have suspected CMV for maintenance also because the cost is too high. And if you come to the next article, what we are discussing here, that the treatment for viral uveitis is limited to few weeks, but there they say that if you have a chronic uveitis, you will have to give very low dose steroid for months, and you will have to give an oral antiviral cover. So I think there is a dichotomy in all articles whether you require long-term antivirals. If I'm going to give alcyclovir together in all and varicella UVA. Comment from the other experts.
Hello. Yeah, I'm Dr. Manija here.
Yeah, Dr. Manija.
Yeah. So now I think the important thing for a postgraduate is when you're reading a journal article, how relevant is it in our clinical practice? I think that's why we always look at the journal, how we are incorporating this, the findings and the clinical things into a practice. Now, this study, I think Dr. Balmurugan was telling the CMV anterior uveitis is more, which they started in this study, but in our practice, we don't find more. So this is from a Japanese, from Japan. So maybe from different countries, the etiology, the reason, I mean, it'll be different, whether it is a CMV or a herpetic uveitis. And I think as a postgraduate, I think it's very important from this journal, they have outlined how to differentiate between an herpetic uveitis from a CMV, cytomegalovirus uveitis. That is by looking at the iris atrophy, which is more characteristic in herpetic compared to a cytomegalovirus, where in cytomegalovirus you don't find those iris atrophy much, and the way of the KPs, how the KPs are distributed, what kind of KPs. So these are more important features which as a postgraduate, now the journal gives you an idea, like when you look at a case, how we are going to diagnose a viral uveitis. So one thing is mainly based, first important is KPs. How is the location of the KP? Is it pigmented, coin shape? So based on that, as Yogesh was telling, we don't even need to do a PCR. Just by a clinical examination, we can always make a diagnosis of viral uveitis. And the other thing is look at the intraocular pressure. We know that in CMV anterior uveitis, intraocular pressure is very high compared to a, herpetic varicella zoster or a HSV virus. So this article mainly, I think some features are different, what we don't find in our country, because they said they found a diffuse iris atrophy in CMV, which we don't find any iris atrophy in CMV uveitis here. And pupil is round, whereas in herpetic, you find the, iridoplasia. So you find the pupil size is irregular. It's not, so, those are the key features as a postgraduate to look at it and diagnose. So that's what I would like to say. Thank you.
Thank you, Dr. Manija. Any more comments?
Two
Yeah,
more
yeah.
things. Since this is for postgraduates, there are two other things which probably in their exam it may be asked. One thing is if the intraocular pressure is in the high 40s, how do you go about doing an active step for the PCR? That is one thing for the postgraduate. And do you straight away go and poke a needle into an eye which is having a 40 or a 50 millimeter mercury? One thing. Second thing, there is no mention of immunocompromised state or retroviral status in these patients. So when you speak about CMV, and of course in their exams, this is one of the things which these 2 points come out from the journal article. One is intraocular pressure, how do we manage? And the other thing is the retroviral status or the immunocompromised state of these patients.
The point is well taken, Dr. Yogesh. Even in a case of herpes zoster, what set the stage for the disease to happen? Is it uncontrolled diabetes, or the patient is immunosuppressed, or there is a very severe stress because of comorbidities that needs to be addressed to prevent the recurrence of the uveitis and the inflammation. And controlling those comorbidities like an uncontrolled diabetes will go a long way in handling the inflammation as well.
So I think we had a very fruitful discussion, and I hope students, you have got the important points from all the discussants as well as the mentors over here. So thank you, Dr. Akshat, and of course, Dr. Anup for this first article. Now it's our time to move on to the next article by Dr. Anu Teres, who is mentored by Dr. Nidhi. Anu, you can share your screen, please.
Okay, sir. Is my screen visible to everyone?
Make it a full screen. Yeah, fine.
It's a full screen.
Great.
Am I audible?
Yes, adequately.
So good evening, everyone. Myself, Dr. Annu Teres Taliyet, primary DNB resident of Shankarai Hospital, Bangalore. First of all, I would like to extend my thanks for the entire team for giving me this opportunity to present in such a platform. So I'll be presenting on the infectious uveitis treatment algorithm Titan Report 1, which gives the global current practice patterns for the management of herpes simplex virus and varicella zoster virus anterior uveitis. So I'll be dissecting the article under the following headings: introduction, methodology, results, algorithm and the consensus statements, strengths and weaknesses. So herpetic anterior uveitis comprises around 5 to 10% of the total cases, with a larger proportion affecting the elderly age group, more than 60 years. Out of this, herpes simplex virus and varicella zoster virus are the most important causes in developing as well as developed countries. Both of them share common clinical manifestations like increased IOP, iris atrophy, fine stellate dendritiform or granulomatous keratic precipitates. And there have been a plethora of diagnostic techniques and treatment strategies available worldwide. So the infectious uveitis treatment algorithm or the Titan group was established to develop a comprehensive and practical guideline for the management of patients with viral anterior uveitis. So 2 reports were published by the Titan group. It was published in the Eye in 2023. The first was based on treatment of HSV as well as VZV anterior uveitis, and the second was on treatment of the management of CMV anterior uveitis. So I'll be discussing the first report. So the study design was a 2-round modified Delphi survey regarding the diagnosis, treatment, follow-up of herpes simplex and varicella zoster virus. The participant identities were masked, and ethics approval was obtained from the Postgraduate Institute of Medical Education and Research in North India, and the tenets of Declaration of Helsinki was followed. So the participants were divided into 2 groups. Titan group consisted of a core 24 uveitis specialists worldwide and 3 fellowship-trained uveitis specialists. And total of 100 uveitis experts were co-opted by the Titan, who were members of International Uveitis Society study group, who had a clinical experience of around 21 plus or minus 8 years. So if we look at the region-wise distribution of these uveitis experts, it is very visible from this pie chart that around 49%, that is a major proportion of the experts hailed from Asia, followed by Europe, followed by North America, Australia, South America, and the least from Africa. So the study was done in 2 rounds. So round 1 had 21 questions on different domains, and among which 8 were based on diagnosis, 9 on treatment, and 4 were based on follow-up. And there were open-ended spaces to accommodate expert thoughts on each questions. The responses were captured using multiple choice answers or a Likert scale depending on the presented scenarios. After the round 1, there was an analysis and discussion, and then they moved on to the round 2. So in the round 2, there were 12 questions presented after round 1 analysis by the core team for the modified Delphi survey. Those items which had a less than 65% agreement or an interquartile range of more than 1 were discarded. Then after the round 2, again there was an analysis and discussion. So the most frequent response to a particular question or statement was identified, and median scores for items with Likert scale and interquartile range was used for some other questions. A consensus was said to be achieved when a particular response reached more than 75% of the agreement or an interquartile range of less than 1. Statistical analysis were performed using IBM SPSS statistic version 27. So coming to the response rate, in round 1, the response rate was around 76%, and in round 2, it was around 68%. So coming to the diagnosis and initial investigations, as per the Delphi surveys, sectoral iris atrophy was considered most helpful for diagnosing herpetic anterior uveitis with a 76% of agreement between the experts. Whenever viral anterior uveitis is suspected, approximately 1/3 of the uveitis experts agreed to perform an aqueous tap. But if a classical skin lesion is present, most of the experts would not perform an aqueous tap. That was agreed upon by 64% for presumed HSV anterior uveitis and 74% for the varicella zoster anterior uveitis. So, if at all the aqueous tap was performed, 73% experts preferred to use a qualitative multiplex PCR. Quantitative PCR was unavailable for around 37% of the experts, even though they believed that it was relevant in investigating anterior uveitis. But 35% of the experts were of the opinion that they don't have to perform a PCR as they thought it to be useless. Now, Goldman-Whitmer coefficient was not considered because of the lack of availability of the test and a relatively high cost. And serology was rarely preferred by the experts in case of suspected HSV or VZV anterior uveitis. So coming to the treatment part of it, in case of a first episode, the initial treatment, around 58% of the experts agreed that systemic antiviral therapy without topical antivirals should be used in case of HSV anterior uveitis, and a 60% in case of varicella zoster. Topical corticosteroids should not be administered without systemic or topical antiviral cover. So this was agreed upon by 79% or almost more than 75% in both uveitis. The duration of treatment should depend upon the treatment endpoint. That is the resolution of clinical signs of inflammation like keratic precipitates, cells, flare, and an IOP normalization. And this statement was agreed upon by almost 99% in both the groups. And use of resolution of corneal edema as a treatment endpoint was considered appropriate by fewer experts, that is around 70% of the experts. And 56% of experts agreed that they would continue the treatment if significant corneal edema was persisting, even if the signs of intraocular inflammation was no longer present. So coming to the choice of drugs, oral valacyclovir, because of its simpler dosing, was considered as the first-line systemic antiviral by 67% for HSV anterior uveitis and 73% for varicella zoster. For HSV anterior uveitis, experts agreed that valacyclovir 1 gram should be given 2 to 3 times a day for a course of 10 to 14 days. Or otherwise, acyclovir 400 to 800 milligrams 5 times a day for a course of 10 to 14 days. In case of varicella zoster anterior uveitis, 70% of the experts were of the opinion that valacyclovir 1 gram should be given 3 times a day for 10 to 14 days, or acyclovir 800 milligrams 5 times a day for 10 to 14 days. Coming to the choice of steroids, prednisolone acetate 1% was the primary choice in case of 69% of the experts, and it had to be given 2 to 3 hourly or 4 times a day for 1 or 2 weeks for both anterior uveitis. And topical beta blocker was the preferred primary choice of anti-glaucoma medication in case of 79% of the experts. So coming to the maintenance therapy, and once the initial endpoint is reached, 50% of the experts opted for a valacyclovir 500 milligrams 2 to 3 times a day for around 3 to 12 months for both HSV as well as VZV anterior uveitis. The maintenance topical steroids should be slowly tapered until there is no inflammatory activity, that is around 3 to 12 months. Now, coming to management of chronic anterior uveitis, for chronic HSV and chronic VZV anterior uveitis, long-term maintenance with oral antivirals with or without topical corticosteroids were preferred by around 45 to 50% of the experts. In case of an episodic hypertensive HSV and VZV anterior uveitis, maintenance antiviral treatment was preferred only by 18% of the experts. And if there were more than 2 episodes of hypertensive uveitis per year, a long-term maintenance of oral antivirals and topical steroids plus or minus IOP lowering drops were preferred by around half of the experts. And in case there was a keratitis, that is corneal involvement, topical antiviral treatment was suggested by around 43% experts, and around 65% experts agreed that they would prescribe a topical cycloplegic for HSV as well as VZV anterior uveitis. So in case of a recurrent anterior uveitis, the 68% of experts would restart the initial treatment, but with a longer taper of antiviral treatment in both cases. If antiviral treatment alone without a topical corticosteroid would be used by 83% experts in case of HSV and 84% in case of VZV. Now, coming to the prophylaxis for cataract and glaucoma surgery, there was no consensus on the need for enhanced anti-inflammatory or antiviral therapy or the dosage or duration of prophylactic preoperative therapy. 24% of the experts would start topical steroid 4 to 6 times daily, 2 weeks before the surgery, and taper according to the postoperative inflammation. Perioperative oral acyclovir 400 milligrams twice daily was opted by 25% experts, whereas oral valcyclovir 500 milligrams twice daily was chosen by 17% of the experts. But a strong consensus, that is around 94% consensus, was achieved on the need to titrate the topical corticosteroid dosage in the presence of a viral keratitis. That is, decrease the dosage for epithelial keratitis and increase for stromal keratitis. 71% of the experts opted to refer to a cornea specialist in presence of a keratitis. So with all this consensus, they wrote down an algorithm for the management of these cases. So in case of a first episode of clinically suspected HSV or a VZV anterior uveitis, the main suggestive signs will be unilaterality, increased IOP, decreased corneal sensation, and diffuse or sectoral iris atrophy. But if a classical skin lesion was present, they would go for a treatment directly. But if it was not present, they would always consider a aqueous tap for multiplex qualitative PCR and then initiate the treatment. And the treatment endpoint, as I mentioned earlier, it is the resolution of inflammatory signs and a normalization of IOP.
You're through, Dr. Anu?
Yes, sir.
Okay.
So the consensus statement was formed out after the analysis. So unilaterality, increased IOP, decreased corneal sensation, and diffuse or sectoral iris atrophy are quite specific for HSV and VZV anterior uveitis. Sectoral iris atrophy is critical to diagnosing HSV anterior uveitis. Initiation of treatment can be administered even when the PCR or the Goldman-Whitmer coefficient is pending or unavailable. A repeat testing is not necessary and clinical follow-up is sufficient. Resolution of inflammation and IOP normalization were considered as endpoints, And topical corticosteroids will be given in both cases if systemic or antiviral coverage is also initiated. Corticosteroids and not NSAIDs are the preferred first-line topical anti-inflammatory agent, and neither periocular nor systemic corticosteroid is considered as a role in HSV and VZV anterior uveitis. Beta blocker was the primary choice for lowering IOP, and largely because of the simpler dosing regimen, oral valsiclovir was the first choice of drug. If the patient stops treatment, restarting the treatment is necessary only if the disease activity is noted again. And if there is an active corneal involvement, oral antiviral therapy is indicated. Adding a topical antiviral treatment can be considered, and titrating topical corticosteroid dosage to presence of viral keratitis is also indicated. So, with the study, what was known before was that herpes simplex virus and the varicella zoster virus are among major causative pathogens causing infectious anterior uveitis, which are clinically similar. And there is no firm guideline for the management for HSV as well as VZV anterior uveitis. So, what this study adds is the current practice pattern in the management of HSV and VZV anterior uveitis by uveitis experts worldwide. And several aspects of the management was achieved consensus based on a Delphi survey. So the strengths of the study include that it gives us a treatment guideline in the absence of established standard protocols. The Herpetic eye disease study, or the HEAD study, provided standard of care for management of herpetic eye disease, but with more attention to keratitis, and HEAD study included a lesser sample of iridocyclitis cases. So this shortcoming was also overcome by Titan study. But there are limitations for the study. Variability in the experience and caseload among the experts and unavailability of certain ancillary tests in every part of the world is one major limitation. An uneven distribution, as I mentioned earlier and showed the pie chart, there were more participants from Asia and lesser from Africa. So this led to a bias based on local drug availability. And there was a lack of evidence-based conclusion with a follow-up and no consensus on the duration of the treatment. So this is about the Titan 1 report. Now, judges come.
Thank you, Dr. Anu, for wonderfully presenting the article. Now the article is open for discussion. Dr. Nidhi is the mentor as well as Dr. Minija is there. So please your comments first and then we can have further discussions if you want to highlight something more.
Thank you, sir. So we took this up. We can understand after all these discussions from the first and the second study why we are talking so much about this is because these HSV, VZV are known to persist within the ganglion, trigeminal ganglion, and neurological, they are neurotrophic viruses. So they produce a very chronic recurrent form of a disease. So, and in the absence of any proper evidence-based, case control trials, we don't have how to treat them and for how long to treat them, because most of them are chronic and recurrent infections. So, and then also diagnosing them is difficult because there is no form of, microbiological diagnosis is very difficult. So most of it is molecular. We are depending a lot on the identification of the DNA of the virus from the aqueous sample. And the amount of aqueous sample which can collect from the eye is also very limited. We cannot take a very large sample. And apart from that, the PCR availability and then its sensitivity. So even false negatives are quite high with the PCR, with herpes, all of these viruses. So coming to a confirmatory diagnosis many a times becomes difficult. But when we have this typical clinical features as the first journal suggested, as well as what we were saying, it's more easier to make a diagnosis of this infective viral anterior uveitis. So once we make a diagnosis, because there's no evidence as we suggested, this a survey form of thing is done based on the recommendations from the uveitis experts about how they go about treating this disease. And based on they have used the modified Delphi and they have used the interquartile range, and so based on that they have been able to come to some consensus on what should be done. and how long should we treat the cases. So valacyclovir was thought to be very effective, like because its dosing is basically it's only BD dosing compared to other acyclovir, which you'll have to take for VZV 5 times a day. And then the duration. So till the time we see that inflammation or a raised IOP, we have to treat, and then we can. But considering that these drugs also have toxicities, particularly when we are using them, we should also do a liver and kidney function test, because it's excreted mainly by the urine and partly also metabolized. So that also has to be kept in mind when we are treating these patients. So that's why that was the reason why this study is useful for us in the clinical practice.
Thank you, Dr. Nidhi. Dr. Anu, can you unshare the screen? We can have discussion, and if need be, we will ask you to reshare. Yeah. So now I invite Dr. Yogesh, Dr. Anu also to join discussion, Dr. Bala, Amit.
Yeah, from the practical standpoint of view, you have nicely highlighted that before starting oral antivirals, we have to document the renal function test. We had a surprise in a clinically normal patient when the renal parameters are altered, because these drugs are predominantly excreted to the renal system. Be very, very careful. And the second point of difference between the second article and the first article is to be highlighted. In the first article, they have also said about the famciclovir, which is used as a treatment. However, the consensus was not reached on famciclovir, and a huge consensus on the valacyclovir and valganciclovir was established in the Titan study. For most of the discussions would have been a part of this Titan network, and we all know that the Titan was a huge success when it started with the tuberculosis guidelines, and we seem to follow a lot of those guidelines. And the Titan 2 from virus and the Titan 3 is on top, so is upcoming. And we need to be the strength of this study was the experts' duration of practice. Even it ranged from plus or minus like 15 to 25. That is a huge strength of the study, and we need to pay attention. And the certain conflicting are so as to put with the magnifying glass, and only 63% of the experts opted to give cycloplegics. That is a point of we need to really pay attention. Why the other people, more than 40 people around those percentage did not want to give cycloplegics was because this viral uveitis hardly forms posterior synechiae. In fact, in our clinical practice, we refrain from using cycloplegics and wait for the synechiae to form. If the synechiae forms in a dense fashion like 360 degree, the possibility of viral takes a backseat. So that is also one practical pearl which we need to keep in mind. And the other controversial thing of both the articles is when to do the PCR. So because as per the Titan study, the indication arises when the classical feature doesn't arise. By the time the topical or oral treatment would have been started. Once the treatment has been started, after starting the oral treatment or a topical treatment or specific antivirals, the sensitivity and specificity of the PCR reports is going to be altered. That we know from the ARN study as well. So that factor is also very, very crucial that we need to pay special attention to. Hope my point is clear. I'll add inputs. I'll request inputs from the other discussions.
Dr. Yogesh.
Yeah, this was as far as the journal club is concerned, this is a different type of study compared to the earlier one. Earlier one was more of a study based on facts. They got data and they got it done. This is a qualitative study wherein they have analyzed the approach of the different people towards a particular problem. However, as Dr. Nidhi said, that because lack of RCTs or randomized control trials in this sector, sometimes we have to depend on these sort of qualitative studies to have a consensus on how to approach our patients. So it gives a rough guideline and some sort of support to us, because earlier when we were treating these viral uveitis on the basis of just clinical features, we were with especially highly toxic drugs and expensive drugs, our actions were questioned. Now with the support of such articles, it makes our life much easier as a practitioner, I suppose. So otherwise, very well. I think more Titan 3, and I think more ones they are planning for other diseases. We are waiting for that. Uveitis, I think Titan has got a big support.
Dr. Anup, you can add upon.
Yeah, fantastic presentation, Anu. Presented. I have 2 points directed at residents. Uh, Very practical ones. You see a viral uveitis suspect OPD, not just about topical steroids and cycloplegics, add an oral pill. Very basic there. Start from Acivir, Valcyclovir. Acivir is a bit cheaper. Valcyclovir would be a slightly costlier one. Famciclovir is a fancy new addition, as this article showed us. Suspect the virus uveitis with very high pressures, diffuse anti-uveitis from the beginning, stromal keratitis from the beginning, non-responding to your treatment. Think of CMV and maybe take a TAPS and do PCR would be my take on that. Second point I would like to highlight for residents is never in medicine, not just ophthalmology, we taper antimicrobials. We never do that. Never taper antibiotics. This is one area when either for posterior uveitis or for anterior, we give an induction course and a maintenance course. So in induction, we have higher dose of antivirals. Maintenance, we have a lower dose. It's a very rare scenario when we taper the antimicrobials, which is generally not done in medicine. The reason being what earlier discussants discussed, the virus lodging into the ganglions amongst the very major problem causing the recurrences. We need those maintenance levels. So I think those would be my concluding points for residents today. Dr. Prashant Bhavan, sir.
Sir, can I ask something?
Please.
Similar, yes. So related to maintenance dose, only I have doubt that if a patient is on maintenance dose and again we notice the recurrence of the disease, so the doses to which we step up would be equal to, or should we it be greater than with what we started? How would we manage it? Did the study say something about it? About the recurrence, managing the recurrence?
I think
The
Dr.
recurrence
Anup
is
can-
corneal or it is uveitis. The article clarifies if there is a corneal recurrence, then you have to give antiviral more. If the recurrence is more uveitis, then you can think of slowly tapering the steroids.
Thank you, sir.
Dr. Amit, your take on it?
Yeah, these guidelines are very practical and they have removed all the controversies. So if one were to go to the guideline, I think it's a very good article where you can really apply it in your OPD. One is that, yes, that we require maintenance dose. We don't think of treatment of 2 weeks. And we taper the steroid over months. Sometimes these patients also may require just one steroid drop a week. And the other thing is, the other controversy they have said is that the corneal edema may resolve more time. Sometimes you may have endothelitis only, which you will see the corneal edema, you will see in a dilated pupil in retroillumination. You may not pick up the corneal edema gradually on the slit lamp, but in retro you may do. And the other thing which I do is I do a specular microscopy. If I find that the specular microscopy is altered, means that there is a slight corneal edema in that area. Sometimes the corneal edema may take months or may just recover. This article does not say there is a controversy whether the corneal edema should be an endpoint for treatment.
Yeah. Dr. Bala, your take on what Amit has added to it?
Yes, sir. Yes, sir. I like this approach of measuring. Using the when the gadgets are available, there is a latest confocal grading system of the keratic precipitate, especially in the viral uveitis. For cases which are not responding, Dr. Padumali has published how to differentiate a fuchs uveitis caused by cytomegalovirus from the other type of viruses based on the characteristics on the specular as well as the confocal. So that is little on a high end from a postgraduate level. However, those of you who are interested can refer. And all the pearls in the Titan study are really, really practical, and it really clarified a lot of the issues because there was no consensus achieved on in a case where there is an previous attack of viral anterior uveitis, whether or not you will give a prophylaxis before contemplating a cataract or a glaucoma surgery. Consensus was not achieved. That is a point to be noted. However, in our practice, we do give a prophylaxis because the question that is asked for the exam is what are the uveitis that can flare up during cataract surgery? Is viral, toxoplasma, Hansen's is ready-made answer, which we need to keep in mind. Thank you, sir.
Thank you. Any comment? Dr. Minija is with us.
I think everybody's covered most of the points. Thank you.
So I think we had a very fruitful and an interactive discussion over both the articles. And in fact, it was an eye-opener also for a person like me who is not much into uveitis. Whenever it comes, we try to shy away to the UVA department and get rid of it. So great learning, at least basics I can teach, means practice from this particular two articles. Thank you, both the presenters, Dr. Akshat as well as Dr. Anu, for wonderfully presenting. We are really proud to see the confidence of these residents, the way they can come and present their articles in front of, so many audience. We have a viewership of more than 1,500 to 3,000, 3,500 within 7 days over various medias, and the confidence with this younger generation is really awesome. I'm really proud of this younger generation, and we are seeing a good future for our country. The only reason why we initiated Journal Club was, unfortunately, in many of the institutes, we are not seeing Journal Club, and that has gone almost into extinction. And that was precisely the reason why we wanted to get it incorporated in our PG teaching activity. And with this type of a presentations and with the dedication of a mentors like, Anup and Dr. Nidhi, and also the discussants of the level of Dr. Ahmed, Dr. Bala, and Yogesh, I'm sure we will be able to revive this dying art of journal club from in our country amongst the postgraduate education. We can have them more frequently, and this will get replicated at various colleges in our country. This is the ultimate aim. So thank you once more, all of you, for contributing to this particular journal club. I have no more words to express my heartfelt thanks for sparing your valuable time on this day for the young Turks who are the future of our country. Thank you once more, everyone. And my special thanks to Dr. Minija and my dear friend Sudarshan, who helped me in picking up the presenters and the places and the articles for this particular episode. Thank you, one and all. It's time for us to say goodbye, dear friends, students. So we'll be meeting on the next Thursday again at 8 to 9 p.m. for another article, which it will not be a journal club. It will be a didactic lecture on another topic. Till then, thank you and bye-bye. Good night.
Thank you, Dr. Prashant.
Thank you, sir.
Thank you, sir.
Thank you once
Thank you,
more.
sir. Thank you.